I will try to be as evidence-based as possible today. So the learning objectives for today. So I'm hoping that by the end of the session, you'll be able to list some key precipitating factors for delirium, to be able to select appropriate screening tools, to describe some strategies to prevent delirium, to be aware of the association between COVID-19 and delirium, and then to outline some management approaches. So what is delirium? It's an acute disorder of cognition. It's brain failure, acute brain failure, essentially. And to note, it is really poorly understood from many perspectives, but it's a common, serious, costly, and often under-recognized syndrome, and it's associated with a high mortality rate. The DSM criteria are listed here, but the first thing to note is that there's always a disturbance in attention and awareness. It develops over a short period, it represents a change from baseline, and it tends to fluctuate in severity during the course of a day, so there's often day-night reversal. And then in addition to this, you have to have at least one additional disturbance in cognition, and it could be in any area of cognition as listed here. And it's not another condition, and there is evidence from the history, the physical exam, or lab findings that the disturbance is a direct physiological consequence of another medical condition or substance intoxication or withdrawal or exposure to a toxin or, as is often the case, multiple etiologies, multiple causes. And these are some of the overall findings and changes that we see. So a disturbance of cognition, psychomotor disturbance, so people may be agitated or very slowed down. Emotional dysregulation, so there's often changes in emotional state, and that can change rapidly. People are often fearful or anxious or irritable. This, as I said, day-night reversal, circadian rhythm disturbance, and the impairment of consciousness and attention is critical. This comes from a great paper by Jose Maldonado, and we'll give you the reference to that later. If you really want to delve into what we know about delirium these days, this is a great paper. But this sort of outlines the disorder. And one thing to note there is that he describes subsyndromal delirium. So there may be mild delirium that doesn't meet full criteria. And that often we see hypoactive delirium, where people are very slowed down and withdrawn and apathetic, versus the classical hyperactive type, where people are very agitated and distressed and often have psychotic features. And at the most extreme, these are called excited, as in catatonic excitement, or catatonic retardation at its most extreme. The thing to note here as well is that the outcomes are variable. We always used to say that delirium was completely reversible. Thinking on that has changed somewhat in recent years, in that not everyone returns to normal after an episode of delirium, particularly older individuals or those with cognitive impairment to begin with. So we can talk about that later, but it's an important point. A very brief case example. This would be a typical case, really. Mrs. A, she's being seen in a general hospital by a psychiatric consultant. So she's 81, retired school teacher. She's had surgery for a hip fracture. She lives alone. Her husband had died 2 years earlier. 2 days post-op, she's suddenly agitated, disoriented. She has visual and tactile hallucinations, paranoid delusions. She thinks that the medical staff want to harm her. There's day-night reversal. She wants to leave the hospital, and someone's already been in and given her intramuscular, high-dose intramuscular Haldol. She was also briefly put in physical restraints. And her medical history: hypothyroidism, mild hypertension, urine incontinence, high cholesterol, and a cholecystectomy. These are her current medications: the thyroid, diuretic, oxybutynin, aspirin, torvastatin, and she uses Gravol sometimes for sleep. Occasionally uses her daughter's Zopiclone. She's restless, distractible, tremulous. She has a sensation of bugs crawling on her skin. Her mini-mental is impaired at 18. Her clock drawing is disorganized. She has mildly elevated liver function tests. So in the chat, could you please name one likely cause for her delirium? And there is no right answer. There could be a lot of different causes. She's had major surgery. So it'd be great if you could just put something in the chat. That's great, thank you. Thank you. And a bit more history. So the family reports that Mrs. A enjoys several large martinis every evening before dinner. And she's been drinking more since the death of her husband 2 years ago. And there's been some forgetfulness. And she's had falls in the recent 4 months. So now in the chat, could you please name the most likely cause for her delirium? So I'm actually not able to see the chat. This is one of the limits of Zoom, but Sid, did anyone get the right answer?
Everybody got the right answer, David. Yes,
Oh,
absolutely.
That's impressive.
A very impressive group.
That's great. Excellent. So, so how common is delirium? And it really depends on the population we're looking at. So out in the community, older adults, prevalence is quite low, very low. But as soon as you get into medical situations, hospitals, the rates climb dramatically, as you can see here. Post-operatively, very high rates. Hip fracture in particular, being such a major operation, 40 to 50% may develop delirium after a hip fracture. Not well studied in long-term care facilities. Although one study over a year looking at long-term care found an incidence of actually 18%, which is pretty high. And a study from Ontario found 40% over 3 years, almost 3 years. Very high rates in palliative care and intensive care units. Just a few words about the overlap between the 3 Ds of geriatric mental health: dementia, delirium, and depression. They do overlap a lot and often. And certainly people with dementia often become delirious. And there may be features of depression. And this is from the RNAO. And it differentiates some of the main things to look for when trying to differentiate between the 3 Ds. And we don't have time to go into this right now, but you have it in the slides. And obviously the course is very different. The onset and the course are different. The duration is usually different. And the incredible challenge with attention in delirium is different. And thinking is definitely very different between the 3. Whereas in a depressed person, you're going to see often, themes of very negative thinking, hopelessness, helplessness, guilt, etc. Some of the predisposing factors, the things that make you more vulnerable for becoming delirious: increasing age, obviously cognitive impairment, any changes in overall function, sensory impairment for sure, dehydration and malnutrition, drugs, which we'll mention in a minute, and really any coexisting health condition, particularly severe medical illness. And the precipitating factors: drugs. So we always watch out for, look at the drugs that a person is taking, the medications, psychotropics, narcotics, anticholinergics, and then withdrawal, as with Mrs. A. Infections, surgery itself, physiological changes such as hyponatremia, any kind of brain disease, especially an acute illness, major organ failure. And then there are other things that contribute, such as the environment itself. So intensive care units, for example, can contribute to the development of delirium, but they're not going to cause it. And sleep deprivation, stress, inadequate pain control, amongst others. There's a very long list. What do we understand about the pathophysiology of delirium? From the Maldonado paper, these are things that are important. So neuronal aging, neuroinflammation, oxidative stress, changes in neuroendocrine function, circadian dysregulation, neurotransmitter changes, and actually disconnectivity between brain networks. All of these are at play potentially. And this rather old slide actually looks at the different neurotransmitter changes that we might see in the brain. The cholinergic inhibition we know is important. So drugs that are anticholinergic can certainly precipitate delirium, but there are many other disturbances of neurotransmitters potentially. And the anticholinergic side effects, as listed here, a person clinically may be hot as a hair, dry as a bone, blind as a bat because vision can be impaired, red as a beet, and mad as a hatter. Delirium is surprisingly still often under-recognized in various settings, partly because of its fluctuating course, its overlap with dementia, lack of formal cognitive assessment in many settings, and neglecting to determine that this is an acute change, and just an underappreciation of its importance, as well as ageism. There are a number of guidelines out there that are helpful. CCSMH guidelines originally came out in 2006 and then were updated in 2014. There are clinical practice guidelines from the American Geriatric Society on post-op delirium. There's an excellent document from Scotland from last year, for 2019, that you might want to look at. What about screening? So these are from our Canadian guidelines. So the recommendation is to use the CAM, the Confusion Assessment Method. There are other instruments that could be used, including one that's used specifically for alcohol withdrawal, the CWA. This is the CAM, so it's used a lot in hospital settings and other settings. So in order to be CAM positive, you have to have an acute onset and fluctuating course. You have to have inattention, and then either C or D, which is disorganized thinking or altered level of consciousness. If you're CAM positive, you need to be checked out because there's a high possibility of delirium. This is the MOCA, of course, and just to note that there are various items on here that would be very helpful in trying to rule out delirium. Actually, a clock test is often abnormal, but tests of attention in particular may be abnormal. So getting an individual to do some of the simple attentional tests, or even others like just counting back by ones from 100 may be quite difficult for people who are suffering from a delirium. And as mentioned before, the outcomes are variable, but there's certainly a lot of negative outcomes usually compared to a non-delirious population because people with delirium are very ill. So there's increased length of stay, increased mortality, increased institutionalization, and sometimes persistent cognitive impairment. What about the actual experience of delirium? What effect on patients and family members and staff? And it's interesting that the rates of recall do vary a lot, but delusional or dreamlike recollections from intensive care units, from survivors of intensive care units are reported to be between 20 and 75%. The prevalence of post-traumatic stress disorder related to the experience, about 20% in ICU survivors. And it's also, of course, very stressful for families and staff. I remember when my mum had an episode of delirium during her later years, and she described it very vividly, actually. And she said it was like living in two different worlds, was the way she described it. She fortunately made a good recovery. What about delirium in COVID-19? Well, it's been described as a missing piece in the puzzle. And there have been interesting studies from China, from Wuhan, published in JAMA, where neurological symptoms of various sorts were seen in about a third of the patients. And an interesting study from France, where about 65% were CAM positive and 69% had agitation. So there are many potential contributors to delirium from COVID-19. So direct invasion by the virus of the central nervous system, induction of inflammatory mediators, secondary effects on other organ systems, the effect of sedatives, prolonged mechanical ventilation, immobilization, and so on, and of course the isolation. This is a great paper from Poland by Kotwis et al. We can give you the reference for this, but it really is an excellent paper describing some of the challenges of caring for individuals with delirium during COVID-19. And it's very wide-ranging in its recommendations, including looking at things like the need for spiritual care and support for the staff, as well as all of the need to care for family members and have virtual cares, virtual connections with family, etc. It's an excellent paper. So a quick poll question for you. How often can delirium be prevented in hospital settings? I get to answer my own question. That's very good.
Vote early, vote often.
Right. Thank you.
I'll let it go for just a wee bit longer because it looks like we still have more folks entering their answers.
Sure.
Okay, thanks. Can you see the answers, Dave?
No.
So we have a winner. 39% of people said 65% of the time.
Okay.
30% of people said 90% of the time. And then about 15% said 50%, about the same said 33%, and 2% said 15%.
Okay, I see it now, actually, yes. So actually, and this is from some studies, but the answer is probably about a third of the time, 33%. So these are some of the strategies to prevent delirium in older adults. This comes from actually from the HELP program designed by Sharon Inouye, who's one of the gurus in the field of delirium, and the whole HELP program that was devised by her and her team. So, but yes, so stimulating the mind, promoting mobilization as soon as possible, helping with sleep, but not with drugs, making sure individuals have their aids to improve vision and hearing, staying hydrated, and good nutrition. And this is actually a poster from the HELP program that many hospitals have employed, often using volunteers to mobilize a lot of these very basic requirements. And her landmark study, published now over 20 years ago in the New England Journal, found that using this intervention, the incidence of delirium dropped from 15% to about 10%. So moving quickly to the management. So, what investigations should be carried out? So here's a list of some of the routine investigations that should be conducted on, ideally, as in guidelines are always utopian, but ideally, these would be a sort of standard set of investigations. But I think most good clinicians are guided by the history and the physical exam in deciding which tests to do, and also by the setting. It's easier to do a lot of tests in a hospital setting than, say, in long-term care. So we might want to talk about that later, and I think that may come up in our case today. So there are many non-pharmacological approaches that are critical, of course, including treating whatever is causing the delirium if we can identify it. That's obviously critical and will contribute to the recovery. We want to make sure the person's safe and doesn't harm themselves or others. And there are a whole variety of environmental approaches that are critical too, including optimizing the sensory environment. We don't want deprivation or overload. We want clocks and calendars and familiar objects and families if possible, not so easy at the moment. But, I love this one, we avoid putting delirious patients in the same room together. And quickly moving to the pharmacological management. So here's the main point, that we only use medications for those in significant distress due to agitation or psychotic symptoms in order to carry out essential investigations or treatment, or to prevent the person from endangering themselves or others. And in the absence of psychotic symptoms causing distress, the treatment of hypoactive delirium, we don't treat it. There's no reason to treat it with a psychotropic medication. Now, if we do need medication for severe agitation or psychosis associated with the delirium, antipsychotics are the treatment of choice. With the exception of withdrawal from alcohol or benzodiazepines, where a benzodiazepine is the treatment of choice. And low dose of haloperidol or an atypical antipsychotic would be considered, such as risperidone. If the person is known to have Parkinson's disease or Lewy body dementia, we would prefer an atypical agent such as quetiapine. And we use very low doses of haloperidol, at least to start with, and it can be given through multiple routes, of course, including IM and actually IV, even though never approved for IV use. And not 5 milligrams, as in Mrs. A. Now, again, this is utopian, but we would recommend a baseline EKG prior to starting haloperidol, because there is a risk of cardiac arrhythmias, torsade de pointe, sudden death even. And then benzodiazepines for delirium caused by withdrawal, as I mentioned before, but we do not use them in other forms of delirium. Cholinesterase inhibitors, the drugs that we use for dementia, in theory, these should be good because we know delirium is often anticholinergic. So there have been trials, randomized controlled trials, attempting to use cholinesterase inhibitors, but they don't seem to work. Probably because of the multiple causes for delirium, the multiple neurotransmitter changes, etc. Just to mention a couple of brochures that are very useful to give out to patients and families, particularly families. But this one on the left there is from Scotland, from that same program, the SIGN group. And the one on the right is from the CCSMH, the Canadian Coalition. So the key points. So delirium represents acute brain failure. There are multiple precipitating factors to consider. The use of screening tools such as the CAM are optimal. Patients with severe COVID-19 illness are at high risk of developing delirium, and this needs further study. There are preventative strategies that can reduce the incidence of delirium. Optimal treatment of underlying causes is critical, and the management includes non-pharmacological environmental approaches, and the use of psychotropics should be reserved for those in severe distress or in danger of harming themselves or others. And I will stop there.
That's great. Terrific.